Okay, thank you very much, Harvey, for doing the opening. So we're now on our way, and I welcome our first speaker, Professor Pip Logan. She's delivering our Pam Albany lecture, which is our only titled lecture of the day, and so it honours Pam Albany, who was really a great advocate for this network. She was really passionate in terms of her work for falls prevention injury and other injury areas. And she was really, from the Department of Health, really keen and really worked well to promote evidence-based practice. And that was really a key thing and why this network got going, to try and facilitate what we know in research to make sure as quickly as possible it can be rolled out to clinical care. So that's in honour of Pam. So Pip, you heard a short introduction before. I'll just say that, yes, she was from originally the University of Nottingham in the UK, and she's been out, we're lucky to have her in Australia, up in Brisbane at the University of Queensland, where she's been here since last July and plans to stay for the foreseeable future, which is fantastic. She's got a long CV here, but really she's an occupational therapist by background, and she's really put prime interest in care homes and preventing falls in them. And she's completed a fantastic randomised control trial that she's going to talk about today, as well as what's happening beyond that in terms of implementation. And so the title of Pip's talk is Preventing Falls in Care Homes.
Great. I would just like to say thank you very much for inviting me to come here, and it was great to have that welcome to country that we had earlier on. I am actually an occupational therapist as background, and up till last July I was still treating patients in the UK. I've come to work in Brisbane, as Stephen says, at the University of Queensland, and the STARS, which stands for Surgical Treatment and Rehabilitation Service. It's a standalone hospital, and I also work for the University of Queensland. I'm not working as an OT in Australia at the moment. So I've got my acknowledgement to country, and we normally say this, I always stutter. I was saying to Stephen I stutter of it because it's not something we normally do in the UK. I'd like to acknowledge the traditional owners and custodians of the land on which we meet. We pay our respects to their ancestors and descendants who continue cultural and spiritual connections to country. We recognise their value and contributions to Australia and global society. As Stephen says, I came from the UK. I actually come from the very northeast of England, where I worked as an OT, and then I moved down to Nottingham. I trained in Derby, which is in the very centre of the country, and the work that I've been doing in the care homes across the UK is right across from Scotland into Wales and Ireland. So it takes in a big, you'll know we've got about 70 million people living in the UK, and 421,000 of them are living in residential or long-term facilities at the moment. So why did I do this work? I actually got involved in this work because my clinician friends, the nurses and the therapists who are going into care homes said, there's a really big problem here. We've got a lot more older people moving into residential care and nursing care, and a lot of them are falling over, and we're being asked to go and see them. And we know that, as we all know, that people who are in care homes still can have more falls than often when they were at home. But they might have moved into the care home because of a fall. Families get worried, people get upset by seeing their families on the floor, and then they move them into a residential or nursing home place. We know that up to 80% of people in the care homes have such bad cognitive impairment that they can't make decisions for themselves. They need help, and therefore any of our falls prevention interventions that we've devised for community dwelling adults actually need a little bit of adaptation for a residential care community. And we also know that most of the, up to about 20 years ago, a lot of the work was put into doing falls risk assessments, but not actually into the actions that people need to take to reduce the falls. So we knew someone was at high risk, but we didn't know how to reduce that risk. So I started to get involved, and the intervention I'm going to talk to you about is not really my work. It's a collaborative, creative work that's been done, that started with the care home staff. So those people working in those long-term facilities started this intervention, and in all of the publications you will see their names recognised. So it's called the Action Falls Care Home Programme. It was used to be called the Guide to Action to Prevent Falls in Care Homes, which is a very long name. And about 4 years ago, we changed it to Action Falls. So if you see the Guide to Action to Prevent Falls, it's the same intervention. The care home staff said it was such a long name, they wanted to change it, so we changed it to Action Falls, and actually it's been very successfully adapted to do that. It's an intervention that's aimed at the care home staff, all of the staff. So that's the cooks, the cleaners, the gardeners, the handymen and women who come in, any family members who come in, visitors who come in, Duke of Edinburgh Award Scheme, students who come in. This intervention is designed to help all of those people look at falls in that care home setting. It could be the residents themselves who take part in doing the intervention. Because if we've got 80% who are cognitively impaired, it means we've got 20% still who are cognitively with it. And 20% of 421,000 people in the UK is a lot of people. So that's how the intervention was developed. And there is a program that you can download and have a look at the manual. There's a toolkit that's for free on our website from the UK. The care home staff attend a 1-hour training session in small groups. And it started with this paper, Thinking Falls, Taking Action, over 20 years ago. So this has been long developed and long evaluated intervention. So the key components of the intervention are this checklist. It is about the training, it is about the checklist, it is about going through the things we all know. Are people falling because of medications? Are people falling because of poor lighting? And then the actions are, what can you do about that? What can the care home staff do? What can the residents do themselves? What can the family members do? What could we do with a better, giving people more fluids? How do we get people to drink the fluids when we've actually put the cup of tea or coffee beside them? Is it something that we need to think about, the lighting in the space? Or is it the garden? Or is it the medications that people are taking? And in this action checklist, all of these ideas and concepts that I'm talking about are in there already. So once people have got the checklist and looked at the problems that people are having, the actions are listed so people can follow them. What I then went on to do when we got this really good intervention was I went and applied for a large grant to do a randomised controlled trial. We need the evidence base, we need the cost effectiveness, we need to have that evidence so that politicians and commissioners can say, yes, they've done the trial, it works, let's roll it out. So in 2016, I started this very large study across the UK. Large randomised controlled trial with the usual cluster randomised design, where so each care home was, when they were recruited, were then put into either getting the intervention or not, and then were followed up for a year with lots of outcome measures. There's a big process evaluation alongside it, so that was interviews with the staff who were taking part, and then an economic evaluation. So we could actually then say to our commissioners and to our government and our MPs, look, this is an intervention that works for the residents, but it also is cost effective in the NHS setting in the UK. So remember, this was in the UK. But since I've been in Australia, and before I even came to Australia, some of this work's rolled out across some of the groups in Canberra and in Sydney and in Brisbane. And going forward, we're looking to do more of this work, and especially now that I'm here, I'm really keen to work with you all and think about how we can do that. So the primary outcome for this trial was the rate of falls. That's what everyone wanted to reduce. And what we took was the rate of falls between 90 days and 180 days after the care home staff had been trained. Because we know that falls interventions don't, we know that falls interventions don't happen straight away. We know that you need to be able to, sorry about this. My thing, turn it on. Sorry, hang on. We know that falls interventions, if you do something on one day, someone doesn't necessarily stop falling that day. It can take a bit of time. If you're doing exercise, if you're doing medication reviews, if you are changing the lighting, you're putting up handrails, they take a bit of time. So we did this between 91 and 180 days. We also looked at the way that people were having a process evaluation. So what was happening? Did the care home staff use the intervention? Were they able to implement it? And we did that through interviews, using the normalisation process theory to analyse the results. And there were secondary analysis that were... all right. So there were secondary analysis, so also, as well as doing the secondary analysis, we looked at a massive range of outcomes. So we looked at their activities of daily living using the Bartel, we looked at their mobility, we looked at their quality of life, we looked at their medications that people were taking. Probably a little bit small on this slide, maybe you can see it, but this is the baseline characteristics of the populations. And as you can see the GTACH was the Guide to Action to Prevent Falls, which is now, I told you, is called Action Falls. And then there was the usual care group. And we've got the overall, this slide just shows to compare the two groups that were given the intervention. You'll notice that the Bartel score is quite low, indicating that these people are quite dependent. Most of them need help to move around the care home. They needed help with washing and dressing, and they were needing help to get showered and up and down stairs. There was an older group of people, so these aren't the 60-year-old people living in the care homes. These were the people in their 80s living in the care homes. So what did we find? This has been published in the BMJ, so you can look at the papers. So there's a massive report that goes with it. But what was really exciting was that in that primary outcome point of time, 90 days after the care home were trained in the intervention, there was a significant drop in the rate of falls. And the drop was 43%. So we got a massive drop in the rate of falls for the care homes who had been trained in the intervention and then had used the intervention. We also got a drop in the falls before that, but the yellow bit shows the drop for the primary outcome setting. So 43% is a massive reduction for a care home setting, considering these people, most of them, as you say, 80% of them aren't able to do the actions themselves. This is the staff and the family and the friends who are visiting doing the actions. And what we also found was that it was economically viable. So this is a relatively cheap intervention to have in our, in our health service in the UK, health and social care service. The care homes in the UK, all the care homes that were in part of this study were all privately owned. They're not social service owned homes or health homes. They're all private organisations. So actually, this was quite a good outcome to get an intervention that they could see that they could invest money in and get a good return on investment. And in the process evaluation, we found that actually the care home staff liked the intervention. They liked being able to do it as a group. They liked that the cook and the cleaner and the gardener were involved, their managers were involved. They liked the fact it's a 1-hour training, and they liked the fact that it was an intervention that they'd helped develop. It was the wording was in their words. I know that there is, the work I've worked with in Australia is that they've looked at the English wording, and we do need to change some of the wording for an Australian context, so that's some work that's ongoing. So then I went on to look at how we could implement it. So we got this really good result, and we now had 15,000 care homes across the UK to get on board. 15,000. So that's a lot of care homes to actually say, right, who's going to start using it? How are we going to help you use it? It's not a case of just publishing it. and then hoping people would take it up. It's our responsibility as well to make sure that we make it as easy as possible for people to use these evidence-based practices. And what we did was a care home study with another 60 homes. We took the 60 homes we took this time were ones that were much more, they weren't research-ready homes. These were care homes that were having high levels of falls rates in their care homes. They were in specialist, in sort of more socially deprived areas of the UK, and they were often care homes that had specialised into one community, so like a Bangladeshi community, or a care home that had people from the Jehovah's Witness religious group. So a very different type of care homes, much more challenging to engage with, but actually people had a lot of falls in these care homes. We went and trained over 1,000 members of staff again, and we collected falls data. We did interviews with all the care home staff to see what the barriers and facilitators were. And we used events, collaborative events, a lot of communities of practice, bringing care home staff from different homes together on Teams, on Zoom, to talk about falls, to think about how to deliver the action falls, to think about what they needed. And we got some really good results and some quite interesting results as well, which obviously are what you want when you do research. You don't want everything just to be brilliant. So we did a lot of interviews. We found that the care homes that had engaged with the training, engaged with the process, still had the significant reduction in falls. So it was about the training, it was about the implementation of putting it into practice. But what we also found was that the care homes staff struggled to complete the documents. A lot of care home staff are not the people in the office writing up the notes. They're the ones taking the tea round, or they're the ones doing, cleaning the floors, but they're not the ones maybe writing the care records or typing the care records. Over this period of time, 80% of our care homes in the UK turned from being paper-based records to digital records. And I imagine that's the same in Australia. Most people have got digital records. The problem in the UK was that there was 51 different types of record company. So we want to put our action falls onto a digital record company basis. 51 companies had to be encouraged to put it on there. And that is still an ongoing problem to get that to happen. And I imagine you've got the same across Australia as well. We move on in time and it gets less and less. They tend to coalesce together, but at the moment still there's 51 of them. So, the other thing we found there was that we could train the care home staff, but they still needed support afterwards. They still felt unsure. And the training was delivered by healthcare professionals in the UK. And so what was happening was the care home staff were having the training, but then 2 or 3 weeks later were ringing up the physio saying, "Oh, could you pop back? We didn't quite understand." So that was something that we had to do. So what have we gone on to do to try and sort out those issues? We've really worked with our NHS organisation in the UK, and we've been able to get the action falls embedded in policy at the highest level. And this helps with funding, it helps with getting our global reach across the country. We've written a lot of policy documents, and we've visited a lot of MPs, and we've been to a lot of roadshows to promote action falls at that level. And that's having some effect. But as you know, MPs change, governments change, and so we're constantly needing to do that in the care home world in the UK. We've done YouTube films to make sure that we've got access for everybody to have a look at it, and we've got an app so that people can download things. We've got online training now, so people don't have to do we haven't got online training for the care home staff yet, but online training for the NHS staff, who there would then be the falls champions to go out to the care homes and train the care home staff. Just to make things more accessible and more broad across the country, across the UK. We've got some lovely infographics that we can, I'm sure this is getting handed out to you all, so you can have a look at these infographics that make it easier for people to hand out to their care homes or to their long-term care facilities in an easy-to-read formats with the results on them. And we've really been able to think about how we're going to take this forward and invest in more research to help people take it part. So in conclusion, we know that this action falls can reduce falls in your care home residents by 43%. We know it's cost effective, and we know the care home staff like to use it, they love the training, and they love being able to be a community of practice, taking responsibility for reducing falls in their own care homes. But we also know that there's these implementation barriers. We know that we need to be addressing them at a national level in the UK. We know that we need to be trying to address these 51 different companies who've got digital platforms that we need to get it on. And we know that we need to be thinking about how this is rolled out through social care as well. So it's not just a health issue, it is a society issue that we need to look at. So just as a little plug, we have got a study that's going ahead, taking the same intervention in stroke population across the UK and Australia. And some of you are participating in this. So just a couple of names. If you see Fizz coming up around your area, you might be interested to get in touch. It's the main people are from Brisbane, but I know that Kathy's involved and a few others of you are involved in it. So yeah, and it'll be another big randomised controlled trial. It is in stroke patients, but slightly different to the aged care population, but using a very similar intervention. And I'd just like to say thank you very much to my team. The team's very large now, but I'd really like to say thank you to the residents and the staff who've worked in the homes, the clinicians who've really helped develop the intervention, which is a very broad multidisciplinary team. And I'd like to thank the funders who helped me do this work up till now. So thank you very much.
Thank you very much, Pip. So just to present you...
thank you very much.
Albany speaker.
Thank you.
And a gift.
Thank you.
Thank you very much.